Thank you, Dr. Joshi, Dr. Guru Prasad, Dr. Paparu, and all of you. I'm actually from Calcutta. I've been left Calcutta a long time ago. I've been working in USA for last 32 years, and my research is in angiogenesis and diabetic retinopathy, both basic sciences and clinical sciences. What I'm going to do now, I'm going to talk about some molecules that have been now targeted in diabetic retinopathy and macular degeneration, but mainly on DR here. Some of these molecules I have talked about in a review article in Ophthalmology Journal in July issue of 2015, and in the upcoming issue of Indian Journal of Ophthalmology next month, I have an article on these novel pharmacotherapies. But for the sake of time, I'm going to just talk a few important drugs and clinical trials. This is the University of New Mexico in Albuquerque, which is next to Texas state. And actually, I just found out Dr. Paparu did your fellowship from Doheny, and I did fellowship long time ago with Dr. Steve Ryan. He was my mentor at the time. So what are the new approaches of anti-VEGF therapy in DME? There are three things can be done. One is that, as you can see, this is the Funatsu study. If you look at the vitreous VEGF level in DME, there is definitely much higher level than the control patients. But if you look at the levels, it's all over. There are some patients with very high level and some patients with very low levels. So the concept is that if the patient have a very high level of VEGF, maybe you can use higher dose of anti-VEGF drug and may be able to get some sustained better results. So a trial was done, READ-3 study, that looked at two doses, 0.5 milligram ranibizumab versus 2 milligram, almost 4 times, but there is no benefit using the higher dose of ranibizumab. In the RIDE-RISE study, and 0.3 milligram was compared with the 0.5 milligram, and there is no difference, and the 0.3 milligram dose was approved by the FDA. So what are the other options? Anti-VEGF DARPin, which I'm going to talk about, and some of the long-acting anti-VEGF delivery, which can be using some bioerodible implants, microspheres, encapsulated cells, and gene therapy. So DARPin is a much higher potency with a longer half-life of 2 weeks, and one injection, the effect can last for 12 to 16 weeks. You can see here, and it targets all the VEGF-A isoform. It's actually with a partnership with Allergan. This molecule has been tried in a phase 1-2 clinical trial where it has been shown to reduce the retinal edema for almost 12 to 16 weeks, and a phase 3 clinical trial of this drug is now been started in wet AMD patients, and they're also planning to do this trial in the DME patients. The other thing that Genentech is now working on is called the Porch Delivery system, where after the initial injection you are using this refillable, non-biodegradable delivery implant, and a small phase 1 trial was done in wet AMD patients where this bolus dose of ranibizumab is given every few weeks. And this is a system that has been now in a clinical trial called LADDER trial. It's a multi-central trial for wet AMD patients, and there are 4 groups of patients. And again, they are trying to determine the time until a patient first requires this port delivery system implant. Again, as you know, the treatment anti-VEGF injections are going to stay, and it's a treatment burden as you have to inject every 4 to 6 weeks, and all the different drug companies are trying to reduce the number of frequent injections and trying to come up with a long acting delivery system for the anti-VEGF drugs. So the other approach is called the anti-VEGF encapsulated cell therapy, where you have a RP cell line within a capsule, and these RP cell lines are engineered to produce a soluble VEGF receptor protein for at least 2 years. It's encapsulated in a semi-permeable membrane, and that allows this passage of these molecules. And you can see on the left-hand side, the baseline thickening is reduced. This is 5 months later. A multi-center trial using these encapsulated cell system has been initiated in the patients with wet AMD. So the second group of drugs that inhibits multiple growth factors, just not only the VEGF, there are many other factors that are involved in this angiogenesis process, and VEGF is only one of them. So the squalene, which is a small molecule anti-angiogenic drug, actually it was discovered in the tissues of dogfish sharks, has anti-angiogenic properties, and it targets VEGF, platelet-derived growth factor, basic fibroblast growth factor. So it's a more broad-spectrum anti-angiogenic drug. The advantage is that it can be used topically, eye drops. A phase 2 trial in wet AMD has been done already, showing that eye drops and ranibizumab combination is better than just the ranibizumab only. And a phase 2 clinical trial with the squalene eye drops is going to be started soon. Hasn't been started yet, but they are going to plan to start sometime in the middle of this year. So we all know, and I have a talk tomorrow in the diabetic retinopathy session tomorrow, that even although the anti-VEGF drugs are very effective treatments for diabetic macular edema, there are at least, I would say, 30 to 40% patients, I would say the good responders, showing 3 lines of visual improvement, as shown in the DRCR protocol I, right dry study, vivid vista studies, all of those. The good responders are only 30 to 40%. There are some intermediate responders, but also there is another 30% of the DME patients show persistent macular edema in spite of repeated monthly anti-VEGF injections. In this case, like here, you can see this patient had the baseline edema in both eyes, and then got 2 injections of bevacizumab, nothing happened. 6 injections, nothing happened, and then you give a triamcinolone, and you can see a significant difference. So I think DME is a heterogeneous disease with a variable levels of different molecules, chemokines and cytokines. So some patients, it could be the very high levels of VEGF. Those are responding well to the anti-VEGF drugs. And in the other extreme, there are other molecules. I'm going to talk about some of these molecules. So there are some poor VEGF responders. So what are the other molecules beyond VEGF that are now being targeted in different clinical trials and preclinical studies? This is a small list here, I would say, the angiopoietin 2, and you will see in the next, I would say, the 4 or 5 years, this will be the molecule in combination. I'm not saying that this is going to replace anti-VEGF, but this will be anti-angiopoietin 2 molecule in combination with anti-VEGF drug, which is going to meet our unmet needs for the therapy in diabetic retinopathy. TNF-alpha, interleukin, all these are called cytokines, and some of the work we have done in our lab, angiopoietin 2 and TNF-alpha, and this is another hot molecule, is chemokine. We all know that MCP1 is elevated in the vitreous of patients with DME and angiogenesis, along with VEGF and interleukins. Proteinases are also important, and then I'll talk about kallikrein-kinin system. So diabetic retinopathy is an inflammatory disease. All the features of inflammation, leukostasis, microglial and neutrophil infiltration, all the cytokines, you can see VEGF is only one of them, TNF-alpha, interleukin, these are all involved here. And the microglial activation is another important process, and that has been targeted in a therapy called minocycline therapy. Complement activation, increased blood flow and increased vascular permeability and tissue edema. So all the features of inflammation have been described in animal models as well as human diabetic retinopathy, whether in the aqueous, vitreous, and the tissues. So steroids are effective in DME. We all know that. There are 2 studies, a MEET study and FAME study, have shown the effective use of these efficacy of these steroid implants. But what are the other steroids in trial right now? Betamethasone microspheres, subtenon injection of the sustained release drug is in a phase 2, phase 3 trial. These are again all steroid related compounds. Then loteprednol is a topical steroid with a mucus penetrating particle delivery platform in phase 2 trial. Is the oral drug danazol is in trial. And then finally there is a lymphocyte function associated antigen.
Why not make the cornea more regular before you do a cataract surgery? Because then you will be able to implant lenses exactly the way you want. So this was a kind of cornea, decentered, highly aberrated, spherical aberrated cornea, and using a topo-guided treatment you can make it more center. I do not correct a refractive error here. When you are correcting, you can keep the refractive error as absolutely zero. That means the machine only corrects the corneal imperfection or the spherical aberration, and then a cataract surgery little later. So for that you need to be very clear that you should have a sufficient bed, thickness should be there. If there's a thickness, then we call corneal customization and then do a cataract surgery. I'll show some few examples of this. This is a high corneal aberrations, and he also has a lens, and you can't put any kind of lens on this patient because he'll always be unhappy. So what we did was corneal aberration. If you go back to this was 1.51. You reduce it to half of it, and this is a kind of image. This is from the lens which is still behaving oddly. Then you do a cataract surgery, use the ASCRS calculator, and you can see this is the ultimate results. You have corrected both, and this helps us to understand, these values helps us to understand how the cornea is becoming more regular in shape. And this is one case, a small optical zone. You can see this is 7. That means imagine how bad the cornea would be if I had to use a lens on this patient. And zone enlargement, it reduced to as much as possible, and then your final outcome is out here. And this is a topolizer which tells you how we have planned close to around 16 or 17 patients with a follow-up of close to 3.5 to 4 years now. And the last slide which we published in JRS this month, last month, is role of abrometry. This is very helpful. It's not directly linked to cataract, but just one more used in a pediatric OPD is children comes to you always with give them glasses, they're not happy, parents are not happy, the child is seeing double. Many times kids come to us with diagnosis myasthenia or multiple sclerosis at childhood. What happens is, a pseudo accommodation, and this is post cycloplegic. You can see that the whole thing changes. This is one classic example of how this can be used also in detecting, and this is also in our refractive surgery patients who come to you. This was probably for the refractive surgery patient, or one of the patient who complained of glare, ghosting, double vision a week after laser surgery, which is kind of unexpected because the topography was normal. And in this patient we put a drop of cyclopent, this was a drop of homide, and you can see the change happening. The same thing we are using in our pediatric OPD also to figure out the amount of, because there's a huge lot of children who are overcorrected, and they've been used glasses which is very high. So finally, I call it as, in this case, a bespoke customized cornea surgery, and we cannot take chances today because we are more or less telling the patient that we are going to give you results which is something similar to what we would offer to our refractive surgery patient. Finally, the art of doing surgeries, all of us are very good at because we have numbers, we have skill in our country, but the science is what was kind of helped us to get to this understanding. If you merge both, then that becomes a wonderful surgical procedure, what we want to achieve. Thank you.